everyone, and welcome to today's webinar, Children, Families, and Genetic Kidney Disease, les enfants, les familles et les maladies rénales héréditaires. Before I get started, I'd like to go over a few items so you know how to participate in today's event. You've joined the presentation listening with your speaker system by default. If you would prefer to join over the telephone, select the arrow next to the unmute icon on the bottom of your screen in the Zoom toolbar, select switch to phone audio, and then select phone call and follow the prompt to dial in. By default, all participants enter the webinar with audio muted. Today's webinar is being recorded, and you will receive a follow-up email within 48 to 72 hours with a link for on-demand viewing. We're offering this webinar as our first bilingual event using simultaneous translation. You can choose to listen to the presentation that is being given in both English and French by choosing your language preference in the interpretation icon in the Zoom toolbar.
This webinar is the first one given in both languages with simultaneous translation. You can choose to listen to the presentation given in English and in French by choosing your language preference. Just click on the interpretation icon in the Zoom toolbar.
For those of you joining on your computer, you will have the opportunity to submit text questions to the presenters by typing them into the Q&A pane found on the Zoom toolbar at the bottom of the meeting window. Please avoid using the chat box to submit your questions. It helps us to monitor them more effectively when they're all submitted in the questions pane. You may send in your questions at any time during the presentation. We will collect these and address them during the Q&A session at the end of the presentation. In order to protect your privacy, when you ask a question, please do not use your name or provide any other personal identifying information. I would like to introduce our moderators for this webinar, Lydia Lauder, National Director of Programs and Public Policy at the Kidney Foundation, and Hélène Boisvert, Directrice des Programmes à la Division du Québec de la Fondation du Rhin. Lydia?
Thank you very much, Janice. And we would like to thank our sponsors for the 2020 Kidney Foundation webinar series and for making it possible here today. And just one moment, I've lost a few things. So our sponsors, Alexion, AstraZeneca, Horizon, Janssen, Otsuka, Paladin, Sanofi Genzyme. Kidney disease can affect people from all ages and all stages of life. Genetics can cause chronic kidney disease and kidney failure, especially in children and adolescents. Some of those diseases can be rare or ultra rare and can impact the kidneys and other organs. In this webinar, a panel of nephrologists, patients and family members will discuss some of the kidney diseases that run in families, such as polycystic kidney disease, or are considered rare, such as Fabry disease, glomerulonephritis, cystinosis, and atypical hemolytic-uremic syndrome. They will discuss how to have a conversation with your doctor about these diseases, the effects of living with them, and some examples of how families advocate for the care and information they need. We are thrilled to introduce our panel of doctors and patients and thank them for making time to share this important information with you today. We have a lot of content to cover today, so please visit our website to read their complete bios.
Hélène, thank you very much, Lydia. I would like to introduce Marie-Josée Clermont. Dr. Clermont is a pediatric nephrologist at the aHUS Institute in Montreal, Canada's largest mother-child hospital. She's primarily involved in kidney transplantation.
Dr. Paul Goudier has been Director, Division of Pediatric Nephrology at the Montreal Children's Hospital since 1998. His research career spans over 20 years with a particular interest in molecular genetics, a research field that focuses on genes as determinants of all life processes. Dr. Michael West is currently Professor, Division of Nephrology, Department of Medicine at Dalhousie University, Halifax, Nova Scotia, and the past President of the Canadian Society of Nephrology. He's also the director of the Nova Scotia Fabry Disease Clinic and principal investigator of the Canadian Fabry Disease Registry, a national study of outcomes in Fabry disease.
I would like to introduce now Mélanie Antou. She was diagnosed with Alport syndrome at the age of 15. Kidney failure was already present in her family for several years, but until her diagnosis, heredity was not an issue. This is what they believed at the time, 1989. A lab experiment in a biology class in high school 3 with her own urine. She saw results that will be very significant for her and will make a whole difference in her life. After a few examinations and seeing the doctor, given the family history, she receives the diagnosis. Her sister will also be tested, will confirm that she also has Alport syndrome. As far as they know, at least 5 generations in her family were affected.
Sandra Kidston. In childhood, Sandra enjoyed an outdoor life, full of adventure. In 1974, her father succumbed to polycystic kidney disease. At 17 years of age, Sandra married and shortly after had her first son. At 24 years of age, she was diagnosed with polycystic kidney disease, the same disease she had watched her father battle. Sandra had a tubal ligation to stop the disease from spreading to the next generation, but ironically had her second son within a year. He has PKD. At 48 years of age, Sandra began 6 years of hemodialysis. Shortly after, her brother Gary passed from PKD. In 2012, she received her first and only kidney transplant. She has since had a double nephrectomy. The transplanted kidney is functioning at 30%. Ed Koning. In January 2001, after thinking he either had the stomach flu or diabetes, Ed went to his family physician. In a matter of a few days, he was informed that his kidneys were nearly shut down, that his heart was severely damaged, and he could suffer a stroke at any moment. As a result of the kidney biopsy, he was diagnosed with Fabry disease. It is considered an ultra-orphan disease with a frequency as low as 1 in 117,000 people. As such, it's very difficult to diagnose. He was 43 back then and told he will probably not make it to 50. After researching his family medical history, they learned that the longest of any of his relatives lived with this disease was 48. Moreover, the worst part was discovering that there was no treatment or cure.
I would like to introduce Brenda Russell in 2012. Randy retired from the federal public service after 36 years in HR management. He was diagnosed with a polycystic kidney disease at the age of 29. In September 2017, his wife, Francine, gave him a kidney. He was a guest speaker at the Canadian Society of Nephrology Congress in April 2015, and he was given an award for his involvement in person-centered care. I will leave the microphone now to Dr. Clermont. I'm very happy to speak to you today. We will talk about family kidney disease and also some basic aspects. Next slide, please. Family kidney disease in pediatrics, of course, I'm a pediatrician. Very often, the whole family is sitting in front of us, at least one parent, and with the child. We have to start in any cases, we have to go through a family inquiry. It's easier said than done. Sometimes the father is not present or the mother, and one of the parent can be adopted. We don't know about his genetic pool, or the child comes from an ova or sperm donation, which is more and more frequent in society. We have to do a full inquiry. Moreover, we will ask questions about uncles and aunts, the parents' generation. Since families are smaller, parents very often have only one brother or 2, 3. brother or sister. So the disease is not expressed, might not be expressed. So this family history is important, and it is not very easy to do. Next slide. We will talk about the genes. I imagine that you all know about genes. The genome is the whole set of genes that we can see here. There are 23 pairs of chromosomes. There are 23 pairs of chromosomes illustrated on this slide, and on each chromosome that looks like this here, there are genes and intergenic regions. There would be between 20 to 30,000 genes in a genome, but all the genes are not all expressed. Next slide. You can, you know about the DNA. This is the basic of genes, a double chain which is called helix, with the structures relating both parts, and this is on the chromosome, folded on a chromosome in the node of our cells. This is folded on itself, and all the genes are not all expressed at the same time, and sometimes before birth and some after birth. Next, the role of the gene. And now this is a biology class, a high school biology class. These are images from high school, grade 4 I took here. The DNA chain will give birth to an RNA chain, which is a messenger chain with the M, and you heard about the RNA because of a COVID vaccine, which is a RNA vaccine. This will synthesize proteins, create, in other words, protein, and our RNA will be included in this little plant creating proteins, which is the DNA transcription. Now, the DNA will create the RNA, as I said earlier on, and the RNA will program a series of amino acids, which are the little bricks making up the proteins. When the proteins, some proteins have hundreds of amino acids. Now, the protein will be folded as such on itself. I will talk later about mutations and errors. It can be only one amino acid, which is not the right one, or a chain, or a reversed chain, i.e. there's a reversed part of the chain, or a loss of the part of a protein. In the body, the proteins are very important. They will be used for many things, carrying oxygen to muscles, and sometimes they are part of the structure of tissue, like the kidney tissue. The proteins that are in that structure, they are in the collagen, which is a different chain of protein, and they also use as enzyme to catalyze some reactions in the body. They are everywhere in the structure of organs and in the metabolic role, which is the metabolism for transportation of oxygen and so on. They are very important. Next slide. I will say very few words about genetic disease transmission or inheritance. It's the highlights. I think that my colleagues will expand on some data. Next slide, please. We are talking about three types today: the dominant autosomal and the recessive autosomal, and an inheritance related to gender. Now, dominant autosomal is when the gene is in a sick person and it is expressed. So the person is sick, can be sick later in life, but this person can have children with someone who doesn't carry the disease. And this person will, each child will inherit from that disease. Children have one chance on two of inherit from that gene. You need to understand that one chance on two is for each pregnancy. It's not because you have 4 kids like here that only 1 on 2 will be sick. In this generation, the lady, I say it's a lady because it's a symbol here, the lady, 2 on 3 children were sick. So dominant means a sick person that will transmit the disease to one child on 2, and the risk is the same for each pregnancy. And there will be sick boys and girls. And polycystic kidneys, and my colleagues will talk about that. They are dominant autosomal genes. Next slide. Now, it is a bit more complex. These are recessive disease, recessive autosomal disease, which means that both parents are carriers of a gene which is sick. And this is a small r. They are not sick or might be slightly sick. If they have here 4 children, the child receiving 2 good or healthy genes, capital R, is healthy. The child receiving 2 sick genes, like the small r, is sick or presents a disease. And the 2 children in the middle, they receive 1 capital R and 1 small r. They carry the disease. Like the parents, in principle, they will not be sick. And there are few impacts for them, except if they have eventually children with another carrier. We will ask these people very often to go back in genetics when they are ready to have a family, so that the new spouse be tested. These diseases are often found in isolated populations where people used to mate in a restricted pool of people, like it existed before in the Lac Saint-Jean a few generations ago, where there were a lot of people coming from a single family. There was fibrohistic, which is a recessive gene, and many children had this disease. In the Maghreb, Northern Africa, we see many cases of recessive cases. The cystinosis, a case we see often in pediatric nephrology, is a recessive disease. Next slide. This is the inheritance related to X, because the gene responsible for the disease is on the X chromosome, the Alport disease, for example. Next slide. We will explain here what happens. Now, the mother is a carrier of this anomaly, the small blue here. This is the mother. She has 2 X chromosomes. The father has 1 X, 1 Y chromosomes. The mother carries the gene, sick gene. Sometimes she's sick, very often only slightly sick, because she has another gene, which is a healthy gene, X chromosome. Where for the next generation, for their children, it depends on the sick X from the mother. If they have a healthy X and a Y from the father, the son is not affected. If the mother gives her X chromosome to the daughter and the other comes from the father, a healthy X, she will be a carrier like the mother. She will have approximately the same symptoms. However, if the mother gives to the son the sick X and the Y, the son is affected, and a daughter here is unaffected. She received the healthy X from the mother and the healthy X from the father. The father here on the right, which is the affected father, his children, since he will give the healthy Y to the son will be unaffected. However, he will give the unhealthy X to the daughter, and the daughters will be carriers. And this cycle will continue on. Let's go to the next slide. And we will talk about spontaneous mutations. You see a tulip, one petal has a mutation. This is a rare modifications of genes. It can be accidental or induced by radiation or something else. According to the part of the genome, the part of the genes that is impacted, there can be different consequences. Next slide. Now mutations. There are in polycystic kidneys, probably that 5% of people carrying this disease comes from a mutation. Nobody in the family has this disease, but they will pass it on to their children, unfortunately, and there will be up to 15% of the mutation for the Alport disease. Next slide. I hope that you are still following me. Back to this slide, just to show you the protein, the creation of the protein, and I will continue with the next one. So, what it allows us to discover, well, many things. First, over time, we discovered sick genes. The researchers in genetic analyzed genes in the humans, in animals, and we were able to discover and define specifically the sick gene. This allowed us also to define the protein. I told you the gene codes for the protein, so we discovered the sick protein, and in turn we saw the role and the physiology of this protein, what this protein serves. Is it an enzyme? Is it a structure protein? And discovering the role of this protein, probably in some cases we will find a therapy. And also at the same time, discovering the gene, it is possible to do prenatal diagnosis. Now, this is my hope here in this presentation. Next slide. Just to show you here, this is a commercial lab studying genetics and genes, and the physician can send your gene, your DNA, with your agreement, of course, to the companies. There are many of them, and they are able to do genetic studies in nephrology, more specifically, about many diseases. As you can see, the whole list. Other organs have their own genetic studies. Next slide. Now, the prenatal diagnosis, I'm not sure that all of you have heard about this, but it is important. What we do before the child is born, we will look for the abnormal gene, either on Coriolis villi, which is in the placenta. This can be done around the 8th and 9th week of pregnancy, and also the amniotic fluid. This is around the 15th week. We will look for the abnormal gene, and if the gene is present, the family can decide keep the child or not. Next slide. And the more complicated way of having healthy child, not affected is to create embryos from the mother and the father, or even from donation, and to extract one cell of this embryo. You can see the embryo with a few cells, and to study the genes in the cell to see if the embryo is affected or not. If it is healthy, it can be implanted in the utero with a pregnancy with a healthy child. We extract 7 to 10 embryos to find the healthy one. Now, this gives you hope for the coming generation. How do patients come in our office? Very often, children will uncover the disease. They will have blood in the urines, abdominal pain, examination that will reveal polycystic kidney disease, and we will search among parents, grandparents, uncle, aunts, and sometimes it's the affected patients who will bring the children and ask nephrologists what would be the therapy that can be used. There are also issues about insurance. Very often the child will disclose the disease among brothers and sisters, and unfortunately, if it's seen in one child, can exist in other siblings. Reactions, I can tell you for hours and hours how people react to the disease according to the type of disease. In general, it's like any other reaction with a denial, anger, sadness, but at the end the person gets involved in the therapy and also in research. But for genetic family disease, there is a lot of reactions related to the idea of inheritance. When we have children, we feel guilty. Did I do things right? Did I give the child enough vitamins? Did I use a lot of enough vitamins? So when we pass it on to children, now this reaction can be quite extreme and requires some support from social workers, psychologists. I remember one young person said, well, I inherited from my father, but that's not all he gave me. He gave me a lot of beautiful things in life, so I was happy with that. Now the next slide, which is the last one. Last slide I want to show you. This is about the future. You see this enzyme, which is CRISPR-Cas9, which is an enzyme that serves in changing DNA strands. The double helix here that can be not right away, because this is something that is really a medical cutting-edge technology, but there's also ethical issues. Probably it will be possible to change in utero genes or in the embryo. People will not have this disease anymore. So this is what I wanted to tell you briefly. And I think that there are a lot of hope in what I said. Thank you very much.
It's Dr. West here. Thank you very much for the invitation from the Kidney Foundation to talk to you today about Fabry kidney disease. Next, please. So I have some disclosures about companies and things like that. Next, please. So I'm going to talk about Fabry kidney disease. What is it? What does it look like? How to find out who has this? How do we test for it and screening? And importantly, how to treat this, because we now have treatment for this disease, unlike for many other kidney diseases. Next, please. So Fabry disease is named after a Dutch or a German dermatologist, Johannes Fabry, who described this in 1898. He noticed these skin changes. And we now know that this is a metabolic derangement due to decreased activity of this enzyme known as alpha galactosidase A, or AGAL. And this enzyme normally functions within each cell to break down a very large molecule called GB3, which is a fatty molecule with some sugar residues attached to it, and it normally cuts off one of the sugar residues at the end. So when this enzyme is not present or doesn't work in the cell, then this very large GB3 molecule hangs around in the cell. It has nowhere to go. It builds up and builds up and builds up. And that ultimately leads to cell damage and tissue damage and kidney failure ultimately. Now this gene, there's a gene called the GLA gene, which codes for this enzyme, as you've heard very elegantly from Dr. Clermont, how the genetic system works. So we have this GLA gene that makes this enzyme. And if there's an abnormality in the gene, then the enzyme comes out looking abnormal, doesn't function properly. And this gene is located on the X chromosome. So this is an X-linked genetic disease, and you've heard about how the inheritance is with that. So far, there's over 1,000 different mutations described in this gene, and every year there's another 50 new mutations. So there's many opportunities for disease to cause problems with this gene. And so in the bottom left, you see the typical sort of family tree with X-linked. The females that are affected have a black circle in the middle. The affected males are a square box, black box, and the females pass this disease along to half their sons and half their daughters, and affected males will only pass this along to their daughters. But every single daughter will get this from an affected father. And the males are severely affected, and this is illustrated here. If you look at the male will have one X chromosome and one Y chromosome. The X chromosome will carry the altered GLA gene, I indicated by a star here. Whereas if we compare with the females, females have two X chromosomes, and only one of those X chromosomes will have the affected gene with the red star, whereas the other X chromosome that the woman has a normal copy of the GLA gene. And in each cell, there are the two X chromosomes for women, but only one of those X chromosomes is active. The other will be inactive. So that means that females are a mixture of cells that are affected and unaffected. About half their cells should have the affected X chromosome with the abnormal GLA gene active, whereas the rest of their cells are normal with a normal copy of the X chromosome and the GLA gene functioning. So females are a mixture of affected cells and normal cells, whereas every single cell in the male will be affected in this condition. And so the males have much more severe disease. What does this disease look like? Let's look at the next slide, please. So every system in the body can be adversely affected by Fabry disease. The things that are most important are kidney failure, because this is a talk to the Kidney Foundation, so of course the kidney is most important, but there are other organs that are affected. The heart can be involved. The heart gets very thick with heart failure and abnormal heart rhythms. There can be strokes and mini strokes, what we call transient ischemic attacks or TIAs at an early age, under 55. There is typical burning pain in the extremities, the hands and feet, which is due to damage to the peripheral nerves. There can be angiokeratomas, which are small red dots on the skin. You can see in the left-hand panel there, which are typically clustered in the bathing suit area, but can be found elsewhere. As well, there can be problems with breathing, shortness of breath, and they can be misdiagnosed as having asthma, problems with abdominal pain, alternating diarrhea and constipation, misdiagnosed as irritable bowel syndrome, and other features. Next slide, please. So what about the kidney itself? This disease starts in childhood, so it is a pediatric disease with the presence of protein in small amounts. There may be some microscopic blood, and fat will be present. This fatty material spills over into the urine. In the bottom right, you can see what it looks like under the microscope, these little fat globules there. And if we put this under polarized light, then it gives us these bright cross-like structures. So you can identify that without any special stains in the urine at an early age. And on ultrasound, on the right panel, you see there can be some cysts, but these cysts look very different than in the polycystic kidney disease, which Dr. Goodyear is going to talk a little bit about. There's usually few in number. They don't distort the kidney. And the cysts themselves don't damage the kidney as far as we know. So, but there is microscopic damage ongoing with Fabry disease, with scarring that will destroy the kidney function. And by the time someone's in their 30s, we start to see that kidney function is starting to decrease. And the average age of developing kidney failure is 42 in both men and women. But there is quite a range. It can be as early as 19 years and as late as into the 60s. So there's quite variability with this disease. Patients get protein in the urine, which increases over time, and the greater the amount of protein in the urine, then the more rapidly the kidneys deteriorate, and the greater the risk of scarring on both the kidneys and the heart in this case. Women with Fabry disease have much less protein in the urine than men, and their risk of kidney failure is far lower than men because they have less severe disease. Next slide, please. So this is figure shows the development of the disease. The first stage is the deposits of this fatty material, GL3 or GB3. This starts actually before the baby is born. It starts when the baby is still in the mother's womb, and the amount of fatty material increases over time. So the older the individual is, the more of this GB3 they have deposited in all the cells of the body and all the cells in the kidney. And as time goes on, they start developing injury to cells in the kidney. They will start seeing small amounts of protein coming out in the urine, and with more time, then this initiates inflammation and scarring within the kidney as well as in other organs. And with further progression, then there will be actual loss of function in the kidney, which will ultimately progress to kidney failure without therapy. Next slide, please. So this takes a number of many years for that to occur. So how do we make this diagnosis? This is very important. And so we need to measure the alpha galactosidase activity. This can be measured in a blood sample. We can also look for mutations in the GLA gene. That's very important. And we can measure this fatty material GB3 either in urine or in blood, and also a metabolite called lyso-GB3, which is helpful in diagnosis. And we would measure all of these things in a patient to confirm the diagnosis, because none of these tests are foolproof. Note that in females, because they are a mixture of healthy cells and abnormal cells, that many of the females can actually have normal enzyme activity, but yet they have Fabry disease. And their diagnosis is made on the basis of finding an abnormal gene, abnormal mutation in the GLA gene. So they need to have DNA tests done as well. And we know that there can be spontaneous mutations. Dr. Clermont's talked about that already, but the vast majority of patients with this disease have a positive family history, and they know that there's someone else in the family with this disease. But if there is no family history, that doesn't mean that they don't have Fabry disease, but it does often cause a delay in diagnosis of up to about 15 years. And we've heard how kidney biopsy can make the diagnosis, but we always have to confirm it with the gene testing and the enzyme testing. Next, please. So it is important to screen for this disease. It's not as rare as originally thought. In Nova Scotia here, it's actually pretty common. It's 1 in 8,000 Nova Scotians, so that's really not rare at all. It's less common elsewhere in the country, but there are studies showing that in some areas of the world, with newborn screening, you can find 1 case for every 3,100 boys that are born. So really, this is not should not be considered that rare a disease. When we do test for patients on dialysis for this disease or with kidney transplant, we can find 1 Fabry patient for every 250 patients that are tested. So who should we screen? Well, if there is a person with Fabry disease, we need to screen all their close relatives to determine who else in the family has this. And on average, you'll find about 7 other relatives with Fabry disease once you start testing family members. It's also been recommended that we screen high-risk patients for Fabry disease. High-risk patients would be those patients with chronic kidney disease who are attending clinics or who are known to have decreased kidney function where there's not an obvious explanation for this. And it's important to do this so we can identify these patients early. We can provide earlier therapy. We can provide genetic counseling for them, which will help them make decisions about having more children or not. And it can be fairly simply done, especially with these dried blood spots, as you'll see on the right panel here. Using filter paper, you put whole blood spots here, which then allowed to dry, and you can ship these samples off easily in the mail to a lab to get all the testing done. Next slide, please. And this is an example of X-linked inheritance. The arrow shows the black box here representing the index patient, who was a man presenting with protein in the urine and an elevated creatinine. He had a kidney biopsy which showed changes of Fabry disease. We then did genetic testing, and enzyme testing showed that he had low enzyme activity. He had a deletion in the gene which was responsible for causing this disease. And then we tested other members of the family. We tested his 2 daughters, and they were both found to have the disease, as indicated here. He had 2 sisters, and unfortunately, both of them also tested positive for the disease. One of his sisters had a son, and he also has the disease. The other sister has 3 children. The boy was tested, but her 2 daughters have not yet been tested, so we don't know if they have the disease, but each of them would have a 50% chance of having this. And the man in question, his mother, has to have the disease, and indeed she did when we tested her. And she had 12 siblings. She has 12 brothers and sisters, but she refused to mention to any of her siblings that she has this genetic disease. So unfortunately, we know that some of those 12 brothers and sisters likely have Fabry disease, and their descendants, some of them would have it, but we're not able to chase those people down for privacy reasons. So from this one person, we identified, in this case, 7 other individuals affected with this disease. Next slide, please. We do have treatment, which is important. We have non-specific factors like quitting smoking, controlling high blood pressure and high cholesterol. We can prevent strokes with aspirin and other drugs. We can treat nerve pain with drugs like gabapentin and others. And we have measures to reduce urine protein, such as with ACE inhibitors, angiotensin receptor blockers, low salt diet, vitamin D. But we do have specific therapy. We have enzyme therapy. We can make the same enzyme, human enzyme, in the lab and provide that intravenously to patients. And we also have an oral agent called megalostat that can be used as specific therapy for this, in addition to things like kidney transplants and dialysis. And we have new therapies that are coming. We've done gene therapy for Fabry disease in Canada. The first trial was successfully done here, and other agents such as lucerastat and modified enzyme replacement therapy. So things are improving dramatically for patients with Fabry disease. Next slide, please. So in conclusion, Fabry kidney disease affects males predominantly. It starts in childhood and progresses from there. Screening for Fabry disease is recommended in all patients with unexplained kidney disease. We need to treat patients early, starting probably in teenage years. We need to control protein in the urine, blood pressure and cholesterol, and stop smoking. And we can provide specific therapies such as enzyme replacement therapy or ERT and chaperone therapy. But I think the future lies with things like gene therapy, which should be more effective than our current therapies. So I will thank you there for your attention, and I'll be pleased to take some questions at the very end. Thank you.
So this is Paul Goodyear from McGill. Next slide, please. So Dr. Clermont, at the very beginning, pointed out the large number of genetic kidney diseases of the kidney. And I'll just use this cartoon to illustrate why genetic disease has been so important for renal disease. Kidneys are made up of a million of these little units called nephrons, and each one looks like this structure that I've got in front of you. And so this is where blood forms the urine, comes through a filter in this glomerulus, travels downward and all through these various segments. Each one of these segments is similar to a separate organ. It has very specialized functions. It does special things to the urine as it goes by, usually taking back the good stuff and letting the bad stuff keep going. But the point is that each one of these segments needs different genes to make it special. And so the kidney is susceptible to genetic diseases which produce a wide variety of very different sorts of diseases depending on which segment they affect. I'm going to jump in, as Dr. West just did, into a couple of specific rare diseases that affect the glomerulus. That will be Alport syndrome, and the tubules, and that will be polycystic kidney disease. So next slide, please. So I'll begin with Alport syndrome, which was originally called hereditary nephritis. The nephritis, meaning inflammation of the kidney, was not quite right, but the hereditary part was. And the condition was first identified by this fellow, Cecil Alport, nearly 100 years ago. And he recognized the basic properties of this disease. And it turns out, although he didn't know it, turns out to be really a disease affecting the little filter structure or sieving structure that sits on the membrane just below this blood vessel, and which allows fluid to come through and form urine, but keeping back all the red blood cells and proteins and things for the body. So it's a disease of this little membrane. I'll get to that. If you're missing the gene for Alport syndrome, young children begin with just a little bit of blood in the urine. And then as they get older, there is some protein that appears in the urine. So clearly, this filter is not perfect. It's letting blood cells get through and a little bit of protein. And then as time goes by, the same process seems to smear the filter rather completely, and there's progressive loss of fluid that can make it through the filter at all. So oddly, in the beginning, it's sort of a few extra things that come through. And by the end, it's very little coming through. So the kidney is unable to clear away the bad stuff in the blood. And by age 30 to 40, most males with this condition will need dialysis. And of course, many people are aware of this disease, and there's some deafness in about a third of the cases. And there's some changes in the lens of the eye. Next, please. So it is really the electron micrograph. This picture on the left is very, very high-powered type of microscope, which gave us all the images that helped understand what's going on. And if this is a red blood cell, and this is the blood in one of these capillaries, it is this membrane which is the filter. And here my arrow just shows some fluid moving through this membrane and into this space, which is down here. So the nature of this membrane is that it's supposed to look nice and smooth and all the same on an electron micrograph, but you can see here that there are strands that are separated one from the other in the membrane. And people used to refer to this, the pathologist used to refer to this as a basket, like the strands of fibers in a basket, which are visibly distinct. And that's not the way it's supposed to be. So next, please. So let me try to explain our current understanding of what actually goes on in this disease, and then I'm going to move to the genetics. So it turns out that there are actually 3 different patterns of inheritance in Alport syndrome. And this is in part due to the fact that there are several different genes which can be mutated and produce the same syndrome. So the most common is collagen 4A5. This is on the X chromosome, and we've heard Dr. West talk about X-linked inheritance. We've heard Dr. Clermont describe this disease briefly. But there are 2 other genes that can produce Alport syndrome as well. One is called collagen 4A3 and collagen 4A4. And these are on not the X chromosome, but the 4A4 is on 2, and 4A3 is on 13. So here are genes in several different locations in our DNA, but they all produce the same syndrome. Why is that? So I've cartooned the idea down here, and these are meant to be strands of collagen, or very stiff, kind of tough fiber that form the filter, the sieve. And what you see is that the individual strands are cross-linked or joined one to the other by the proteins produced by these genes. So I've just labeled them 3, 5, 4, and so forth. And it turns out that you really need all 3 genes, 3, 4, and 5, to make a nice, firm, resistant filter. And if you don't have all 3, the filter is loosened. And every time the blood vessel expands with a pulse of blood, this filter is stretched a bit. And if it doesn't have these cross-linkers, the fibers will be slowly, slowly ripped apart. Next, please. Next slide. So this is interesting biology and so forth, but who cares? Well, we do care, because a knowledge of what's going on in the to this filter informs us that it should be possible to perhaps protect the filters wrapping this capillary in the glomerulus by taking the pressure off them. And that's exactly what has been tested. By using a blood pressure medicine and reducing the pressure inside with each pulse of blood, the filter is stretched less each day. And this appears to have a very significant effect on slowing the progression of the disease. Next, please. So let's just look at the genetics of this. It turns out to be a bit more complicated than we had hoped, but there it is. This is looking at one of the genes, let's say collagen 4A4, collagen 4A4, both are mutated here, because this is a recessive family with Alport syndrome, meaning that these people who have a bad copy of the collagen 4A4 gene are okay. They may have a little bit of blood in the urine, but perhaps even a bit of protein, but they don't go into renal failure as a rule. But if by luck, two people marry and have a child, and they happen to pass the mutant gene, both copies of the mutant gene to this child, because it's a circle, I meant to say this is a girl, so she will have Alport syndrome. She's a woman, but she's going to get Alport syndrome because in this family, this gene is not on the X chromosome. And when two genes come together, there's that collagen 4A4 protein is completely missing. Next, please. This is the typical or the more common form of Alport syndrome that Dr. Clement referred to. And as we see here, I'll just quickly say that this Y is supposed to be an X. So I meant to say that all three women in this family have a little bit of hematuria and mild proteinuria, but in general, they are fine. They don't need to go on dialysis. But the males who do not have a backup copy of the X chromosome, they get a Y from their father. And they have no backup copy. They have a mutant gene on the X chromosome. And so they are unable to form that important cross-linker encoded by the COL4A5 gene. And they will develop Alport syndrome. Even though this child is 10 years of age and he only has a bit of hematuria and proteinuria, there's no question that this will eventually lead to end-stage renal disease, like his uncle who had renal transplantation and hearing aids. Now, if you just hit the return, okay, if you could go back, please. So what I meant to have happen is that this woman who looks to be unaffected, a carrier like her mother and grandmother, actually turned out to develop end-stage renal disease, and she's on peritoneal dialysis at the moment. So the point being that there, just like some of the other conditions that were discussed, although the primary genetics determines whether you will get the disease or not, how severe the disease is may be modified by other genes that you bring with you, or even by life events. So we now recognize that even carriers, women with a collagen 4A5 gene, may develop fairly severe disease, while others in their same family do not. Next slide. There it is. Okay. So one last point about Alport syndrome, and that is taken from this slide. As I mentioned, if there's a family with a mutation in either collagen 4A3 or 4A4, that one mutant gene can be passed down the generations. But the people who have that usually have a fairly mild disease, a little bit of blood, a little bit of protein, maybe even in the worst cases, some mild renal insufficiency. But the problem is that these families are problematic, particularly for pediatricians, because we see young children who should have no blood in the urine, and they do. And we need to know whether a family like this has passed on an X-linked gene to this boy, and he's going to go into renal failure or not. And so here there is a role for genetic testing, as well as a very careful and detailed family history to figure out whether there's some other boys in this family who went into renal failure. And the genetic testing, if we can't figure that out just by asking questions, genetic testing will tell us whether this boy has a mutation on the X chromosome, in which case he's going to go into renal failure, or on in one of these genes on one of the other chromosomes. So an important role there for genetic testing. Next slide. Yes, we used to call this benign familial hematuria. Okay, it's the next slide. So now I'm going to turn to polycystic kidney disease. This is a rare disease, but it's not so rare. 1 in 1,000 live births is the traditional estimate. Dr. Daniel Bichet here in Montreal has proposed that it probably is not quite this common, but nevertheless, it's a relatively common genetic disease, and it affects about 12.5 million people in North America. So this, of course, is a picture of a polycystic kidney, and it displays, it has been sliced open so that we can see this when the kidney was removed from one of the patients. And what you can see is that there are about 1,000 cysts in each kidney that arise. This actually begins before birth. Little teeny tiny cysts, you can't even see them by ultrasound, and they slowly expand, taking up all the room in the kidney as time goes by. Now, there are two different types of this disease. One is PKD1, or is caused by mutations in the gene called PKD1 on chromosome 16. And the other form of this is caused by mutations in the PKD2 gene on chromosome 4. Next slide. The difference between these two forms of the disease is that PKD1, this is the kidney survival over here now, 100%. For 30 or 40 years, most of the people are not going into kidney failure. But then somewhere about 35 years of age and beyond, the kidneys lose their function as those cysts expand. And so this maps the number of people who need dialysis or transplantation with PKD1 mutations. This maps the same process in, well, we've said here non-PKD1, but it's really PKD2 patients. So it's better to have this form of the disease, PKD2, than this in terms of having kidney function for a longer time. Now, why can two different genes cause the same type of polycystic kidney disease, even though one is a bit slower? And the cartoon below is an attempt to explain that. Basically, the two different proteins, this is an error, should be PKD2, sorry about that. But the idea is that the two different proteins that are encoded by the two different genes work together. And what they do together is as follows. Every cell along the tubule has a little sort of antenna called a cilium that sticks up into the urine. And as the urine flows down the tubule, it tweaks these little antennae, and it gives information that over here is upstream, this is downstream, and that information is used by the cell to know how it should position itself along the tubule. And it needs these two proteins to send that information down into the cell. So if you're missing this one or this one, you get the same problem of failure to communicate. And so the cell is lost. It's lost its antenna, its little GPS. It doesn't know which way is up and can move, or when it divides, it can divide in the wrong direction. And so cysts form in cells which have lost one or the other of these proteins. Next slide. So here's the genetics. This is a dominant disease in the sense that if this father had the disease, he has a 50% chance of passing the bad gene to either one of his kids. And as Dr. Clermont pointed out, it's every time there's a pregnancy, there's a 50-50 chance of passing this gene, because you're selecting either the good one, the normal one, or the PKD1 gene, which has a mutation in it, randomly. So in this simple family, the father and his daughter both have polycystic kidney disease. Next slide. But here's the complicated part of the genetics. when we inherit one copy, and I've made the mutation look just like a minus sign in this nomenclature, in this name. When we inherit one bad gene, actually all the cells up and down this tubule in the normal looking part of the tubule have this mutant gene, but they're fine. So in a sense, the disease is recessive at the level of the cell. But as kidney development proceeds, all these cells are dividing, and every once in a while, an error is made in the good copy. This is the good copy, and an error is made occasionally in the good copy. And then that one cell suddenly has lost both copies of the information it needs to make that antenna work. And so from the side of a normal looking tubule, these cells have lost it. They've lost both copies. And so in a sense, you have new mutations arising all up and down the tubule. They can be in the front end and the back end of the tubule, and these cysts then slowly increase in size as time goes by, and eventually produce end-stage renal disease. So this is the genetics of PKD is complex. For clinical purposes, we just need to know whether we have inherited a bad copy of this gene, because eventually cysts will arise. But the underlying biology may be very useful in the future as we try to figure out therapies for polycystic kidney disease. Next slide, please. Now, this is a long list of things, and I'm not going to go through all these little details, but the point is that, as in many genetic diseases, there are situations where it is quite useful to use current day technology, which has become cheaper and cheaper and cheaper and faster and faster and faster, to identify the exact mutation in a given family. That can help in prenatal diagnosis. It can help in clarifying, if people wish to, know whether a young child is affected or not. And probably as the years go by in the future, it probably will determine whether a given patient is eligible for new therapies, genetic therapies, which are likely to come down the road as the years go by. But I won't go into all the complex decision-making about whether to embark on genetic testing and ADPKD, but it's something which we could spend a long time on, I guess, because it's very difficult for a given family to know whether they should embark on this and what to do with the knowledge. Genetic counseling becomes critical for these considerations. And so most people with young kids now with ADPKD should have at least a careful discussion with a genetics counselor. Next slide. Okay, so I'll just wrap up the my main points, the take-home points. Rare diseases of the kidney are each one rare, but collectively, the group of rare kidney diseases is not so rare. It's common, and the principles of genetics need to be understood and exploited so that we do our best for each rare disease. It's important to know the genetics, and I would hope that each patient, each family understands the genetics of these rare diseases. And if you don't, you can seek out this kind of information from genetics counselors or physicians, nurses, anybody who's expert in that area. I think that another point is that it's important, Dr. Clermont and to some degree, Dr. West also pointed out that to understand the function of each of these genes and why it causes disease is a really, really important bit of research to press for, because it is in the understanding of the function of each of these genes and their proteins in the kidney, that is the information we need to devise new strategies. And The last take-home point, I think, is just the issue I brought up at the very end, that there is an increasing role for genetic testing and precision about the nature of the mutant gene that is useful both for the research, but also important for families in making decisions. With that, I'll quit and I'll speak in more detail during our discussion or question and answer period.
Melanie, we'll invite you to speak now, please.
Yes, hello everyone. I'm very happy to share with you my family story. I'm 47 years old, dental hygienist for 26 years, and I'm involved in Boy Scouts for now close to 30 years. I was diagnosed with Alport syndrome at the age of 15. The family history starts in the years, I would say, around 1975. My father was diagnosed with terminal kidney disease at the time. He was 29 years old. We know that men are struck by the disease younger. However, at the time, they didn't know that it was that kind of a syndrome. It was said at the time that this was following Streptococcus abdominis that he had when he was young, and that damaged his kidneys over the year. Parents asked at the time if there was a problem with heredity, and the doctor said no problem, no risk for children. I was 16 months at the time, and my sister was 3 years old. Years went by, and my father was had dialysis for 23 years. He died at 53 years old after 23 years of dialysis. Around 1980, his mother started dialysis at the time. It was, we don't know why, but she has end-stage renal failure. She was on dialysis for 9 years. At the beginning, she was 69 years. So we see that women have the disease later. During the same years, in 1989, when I was taking a biology class in high school, we were doing a test lab with our own urine. The teacher asked us to do some experiments. On my side, the reactions was, how can I say, was kind of weird. So I went to see the teacher and I told her briefly about the family history. Like my father had dialysis, my grandmother also. She asked me to go and see the college nurse. She referred her to my family doctor. And after we started to go through tests, I saw a urologist, and we were transferred to Saint-Justin Hospital. This is where I met Dr. Clermont, who was my nephrologist at Saint-Justin Hospital. We were tested again with biopsies, and this is where I received this diagnosis of Alport syndrome. My father was tested also, and of course we know that if the father is carrier and develops the disease automatically with the X chromosome, he will pass it on to the daughters. So my sister also has Alport syndrome. We were followed at Saint-Justin Hospital until we at 18 years old with no symptoms. The protein was present in urines, traces of blood also in urines. So years go by, and then we were transferred at Notre Dame and followed for many years in kidney protection. Tests were done in the family. My father had a brother and a sister. The brother was not carrier, was negative, and his sister was never tested. We learned also many years after that my mother's grandmother died of uremia in the years 1950. So we can see the pattern in the family. I'm deaf on the right ear. This affected me, and over the years, in 2008, things are not going so well. Renal function dropped at 30%, and this is where I started to hear about getting prepared for pre-transplantation tests. It took approximately 1 year, and we decided to go towards a living donor graft because 2 people offered to donate their organ. I'm emotional when I speak about this. It's such a beautiful action. So my mother and my aunt, who is my mother's sister, my mother, because of high blood pressure, was refused, and my aunt went through all the tests and procedures, and when my renal function is at 10% just before the transplantation. I didn't have any dialysis. I was lucky. And I received my new kidney in 2010, 10 years this year. I'm doing very well. Yes, there were ups and downs. During the first year, I went often to the hospital, but I'm very happy. I would go through the same thing again without any doubt or resistance. I was well supported by my family, my friends. We do need psychological support, and with the years we develop a lot of resilience, especially now during the pandemic. I'm not working right now. I stopped working. So it's 1 day at a time. And as far as I'm concerned, 1 more year with the transplantation is 1 year without dialysis. So that's the story of my family. We had 5 generations impacted by that disease. And if you want to contact me, if people have the disease, if they want to contact me, ask me questions, I'll be very happy to answer. Thank you.
Thank you very much, Melanie, and I'll hand you over to Ed. And in the interest of time, we'll ask our presenters to keep their sessions to about 2 or 3 minutes so we can have some questions and answers. However, we do invite all our participants today to email questions to us, or if they would like to hear more from the panelists, we'd be more than happy to get you in connection with each other. So I'll head over to Ed. Thanks.
I was born in 1958, and I am the youngest of 3 boys. And I thought I had a normal childhood, but I can remember just a lot of extreme pain in my hands and feet, and not able to sweat. But life went on, and everything seemed fine until I was 43 years of age, and in a very short period of time, I was informed that my kidneys were basically less than 10% functioning, and the result was caused by Fabry's disease. And Dr. West, of course, has explained what that is. And I was basically told that there wasn't any really any treatment, and that from family history and from the medical experts, chances are I'd be dead at 50. Well, to make a long story short, I'm 62 years of age, and I had a kidney transplant in 2001. And as a result of the kidney transplant and enzyme replacement therapy, which is basically a enzyme that is infused into the body, I have actually been able to live well beyond what the life expectancy for a Fabry patient is. And I'd really like to focus on the lessons that I've learned over the past 19, 20 years. And one of the most important things that I've had to come to understand is that I'm really not in control of anything except my attitude towards life. And I think my motto in life has become very simple. If I can get up in the morning and I can go pee, I know I'm going to have a good day. Thanks very much.
Thank you so much, Ed. Really appreciate it, and glad you're here, even though they said you wouldn't be. So we're really pleased that you presented to us today, and I'm sure, Ed, that you'll be open to questions after the event if we need it as well. And Sandra.
Yes, hi everyone. My name's Sandra Kiston, and I have polycystic kidney disease. We shorten that up to PKD. I'm excited to say, like Ed, I'm now 61, and I am one of those people that brag about it because it's exciting to be 61. My kidney has been functioning well, my transplant, for 8 years. So every day is a great day, and that 60-year milestone in our family is hard to reach. And so therefore it's a celebration. Most people do want to hide their age. My father had PKD and passed away when he was 42. Things were much different. In those days, dialysis ran through a wash tub, if you can imagine that, back in those days. And Dad, luckily, was around when they actually came in with a dialysis machine, so we were all quite relieved. And thank heavens, when I listen to Dr. West and the other doctors, I'm like, oh, we've come so far. And there's always more to do, of course, but it just makes you feel glad to see that all our monies and fundraising and things that we do go to such good things, and we're moving ahead pretty fast. So today, I look back and I'm thinking about the things that happened when my father passed, and our family really just sort of fell apart. Back in those days, everything was like a big secret. You didn't tell anyone you were sick. Good heavens, that would mean you were vulnerable. And maybe for good reasons. I mean, today we have counselors and social workers and lots of support. Unfortunately, in our lives, a unscrupulous person sort of made his way into our lives, and after Dad passed, and he nearly took my life in a car accident, and I ended up in a body cast for 4 months. Now, the only reason I'm telling you that story is because obstacles tend to teach us to be stronger, and that's really what I learned from that. That experience taught me how to live, believe it or not, with PKD, to have love and hope and perseverance, and having an excellent medical team is how I not only survived, but I was able to thrive. And I'm very, very thankful about that. I focused on the loving, patient husband who never let me flounder, and my sons who have always been there and very supportive. My brother, who was quite involved with the Kidney Foundation for a few years there. And, and then there's a higher power than me. And I really believe that those things are what kept me safe. I was 6 years on dialysis. I received my transplant December 2012. I will be ever thankful to that family who donated that special gift. Living with kidney disease is challenging. There's dialysis, diets, drinking limitations, exercise, medications, rest, good days, bad days. it's important to control the things you can. Like Ed said, you don't feel like there's many, but you do have them. And just plan every day. I always say to people when they're really feeling like, oh my goodness, I don't know what to do. And just keep on living. Pretend there's a dog chasing you and you don't want him to get your butt. Basically, that's it. Just keep on going and living your life to the best you can each day. You have a good day, just keep on rocking. Basically, that's it. Moving to our next patient, thank you for joining us. Our world is bigger and better when we have each other to talk to and to learn from. Everyone's contributing. Thanks.
Thank you so much, Sandra. It's such a pleasure to have you here together with the other panelists. And last but not least, we'll hear from Randy.
Hello, thank you for your invitation to speak to you today. I also have the polycystic kidney disease. I was diagnosed at 29 years old. My father was diagnosed at 57 years old. He started dialysis. It was a crash start, as we refer to. So his intro to dialysis was quite brutal. I'm call our story business, family business story, because it's been present for 5 generations in the family, at least. My grandfather, and what I have to say today is a message of hope. And like Sandra, my grandmother died because of a kidney failure. There was no treatment at the time. And I was talked about a practice that was used. They called it bloodletting, I believe. My father started hemodialysis and at the center, and then he switched to peritoneal dialysis at home. As far as I was concerned, this was the results were better with peritoneal dialysis. I had a transplantation like in Melanie on September 7th, but that was in 2017. I was moved when I told my family, my friends, my fellow workers that I had kidney failure and I needed a new kidney. I was so happy and proud. 25 people offered to go through the tests and registered for screening and see if they were compatible. At the end of the day, the best person was my spouse, Francine. Francine gave me 1 kidney in September 2017. I have to say that at the beginning, with the drugs, I had some problems with my medication at the beginning. Not because of taking up my drugs, but with side effects. That was a bit difficult. Once everything was stabilized, life is great. And with the polycystic renal disease, the drop in our kidney function was so drastic. Well, in my case, it was over 30 years. But when I was healthy with a new kidney, I didn't recognize to what point I was sick before my transplant. And my kidneys were functioning at 9% before the graft. And another message of hope, my son Chad, for 2 years now is taking tolvaptan, and the results are just excellent, going very well. He runs to the bathroom very often, of course, but his how can I say that? His eGFR is at 78. And my son is not like me, tall and slim, 5'11", and weighs 155 pounds. He lost a few pounds with the drug, but the results are very, very good. And as a parent, that's quite a relief because I felt bad having a child, and I had two, but one who was affected by the disease. I feel guilty. But what is important to emphasize is that with on all 5 generations, at each generation, that was the best treatment. So for those who have the kidney disease now, there's hope, and life is just great after the graft. And thank you so much for the opportunity.
Thank you very much, Randy, and to all our panelists and our experts and everybody who's been here today. We really thank you for joining our webinar. As we've run out of time, and it's amazing, there's been so much information, what we will do is invite you to connect with us if you have any further questions, or to speak to someone in your community, or to access any further educational materials or resources. You can email Janice Melanson at kidney.ca. Thank you very much, and I'll hand you over, Janice, for our final remarks.
So thank you everyone for attending this webinar, Children, Families and Genetic Kidney Disease, les enfants, les familles et les maladies rénales héréditaires. When the webinar is ended, your computer is going to open to a new page requesting that you complete our webinar satisfaction survey. You'll receive also a follow-up email that includes a link to the survey if you'd like to complete it later. Your feedback is important to us, especially this, our first simultaneous translated webinar. We know there may have been some hiccups, and our apologies for that at this point. Hopefully you were able to connect appropriately. You will receive a follow-up email within 48 to 72 hours with a link to view the on-demand recording of today's webinar. We should have one in English and one in French. So on behalf of the Kidney Foundation of Canada, thank you for joining us today. Stay well and enjoy the rest of your day.